Correct.
And you're gonna have to have one more employee.
Because that's 24/7.
Right, it's 24, I know, I have one.
Okay, I just
I'm
want to
trying to
make
get
sure
rid of it,
everybody.
you want mine? No. I'd like an opportunity to really vet this, Doc. Like I said, I'll do assignments at executive today, but I want to share that first when we go too far down this road of renewing a lease or looking, well, Doc is gonna have to look for new lease space.
Right, if something like that is on the radar, we can continue to function where we're at for a period of time yet. And this is a 5-year lease. We always do that because it seems to be such an ordeal to get a lease done each time. But there is a 6-month escape clause in the lease. So if something were to take place, that we had a building that we were going to build or move into, I'm sure it would take at least 6 months for us to move on that, and I don't see.
With a year or 2-year lease, I think we'd be fine. I have some level of confidence this forward, because it's really a small project.
Right, small project, so,
I mean, it's like 4,000 square feet, I mean, that's, you know, it's small and glorious house.
now,
I don't know,
there you go.
I don't know if it is or not, you know. It's smaller than Dan Gould's house.
No, it's not.
It's smaller than my barn.
Oh, there you go.
How about that? So you want us to look at a shorter term lease then, or what's up, Jim?
There's a 6 months.
6-month escape?
Right, that's
So what I'd like to do is send it to finance, so they can look at animal control's dollars, their revenue streams, what they have in reserves,
Okay.
and so forth. And then I'll put it over to capital, so they can start looking. Yeah, I would hope we'll bring out the plans that we have. Can you make sure that they get over to the office?
Do you have a copy of those also, Doc?
I do.
We'll get Dustin up and we can have him review again, so yeah.
Okay.
Uh,
White and Company.
No.
Oh.
They probably have them in their system.
Yeah, yeah.
We have plans to go back to Kelsey.
Yeah, so if they've got them in their system, you can pull them up the cabinet.
Okay, so we'll just go ahead and renew this since it is 6 months.
Well, yeah,
Clause?
I mean, if we get, as long as you're not getting into a long-term lease.
With the 6-month escape clause, I don't know who,
I would just ask the state.
I'm not an attorney.
Looking at that, we're gonna be probably short, term here, probably, I'm thinking 2 years tops.
So then let's wait on this, and can we like move it to maybe executive if you can find us an
and
answer?
his attorney amended the current lease, and they had that before.
See if there's a lease extension and see if we can
Okay.
extend this lease. So I don't know what the, you know.
So we can approve it to move to county board, and if we need to pull it at that time, we could.
Kevin could look at it.
Right, right. Whatever the board would like you to do, we'll make those amendments.
Well, obviously, we're still gonna need space probably for at least another year and a half, I would think.
Change the escape clause to 3 months. Don't feel comfortable with 6 months.
Whatever the state's.
What makes the difference of a 2-year lease or a 5-year lease?
Yeah, if you got
With
6
the
months,
escape
it doesn't
clause.
make a difference, because you'll know before you're
You'll
getting
know.
in. You'll know I can get in
Yep.
4 or 5 months.
The landlord, we'll just give him
Exactly.
that.
Okay, so we will just go ahead to vote to move this to the county board, approve this to move it to the county board. In the meantime, Kevin will look at that information, we'll have it before the board meeting, and then we'll know what we're doing from that point, so.
Certainly, in any direction the board would like to give as to what they believe is proper, I'm more than willing to incorporate those changes.
Okay, so we want to go ahead and look at the lease to see if we can, we definitely have no trouble getting out 6 months. I mean, 6 months is reasonable, I would think. We'll know 6 months in advance what we're going to be doing. It's reasonable, so. Let's make sure that is all very good for us and there isn't anything that would hold us to a 5-year lease.
We'll make sure we can make it clean.
Okay, so we'll go ahead and approve this to move it to the board. Can I motion to approve? Moved by Ferry, second by Rice. But Beth has a question, go ahead.
Well, I completely support a new building. I think how you're approaching it is great. But I did want to clarify about the space needs. I heard several different things. What is available to currently determine your space needs? I know you're contracting out for kennel space, correct?
Yes, we are.
Okay, so does that change the 4,000 figure you quoted, or
No.
is that solid what your organization believes?
I'm going back to what was done previously with space that was allocated.
Okay.
And that was at a time when the county was growing very rapidly and rapid growth projections. And there was far more room and expansion on those plans than what I feel we need at this point. I think 4,000 we could get by with. I think it would be wise, we'd be looking at more in the neighborhood of 6,000 to 7,000. Storage is such an issue for some of the bulk items that we have to order in, shipping specimens, traps that we have to store, and all of that type of thing.
Okay, because I completely support the facility, and I hate to think of county workers working in subpar buildings, but I want to make sure that we have a real good number from the get-go so that this could not be delayed.
I think we need to revisit the
Yeah.
space needs study that was done. I don't think we should go on numbers that were generated 11, 12, 13 years ago.
Kind of what I'm driving at.
Right.
Yes.
Right, and that'll be assigned over to
That
them.
would,
They'll bring that up.
That's why it's gonna be assigned over
Just
to
say
capital.
Once capital gets the plans,
Right.
and sit down with White, sit down and say, okay, based on what we assumed last time, the assumption's the same, something changing. I mean, we may be able to use that, maybe we have to draw up new plans, but
Right, we'll look at it, so.
and it was never to the build plans that
Yeah.
we had to.
just a program
New
plan.
plan.
We're gonna start
Yes.
building next week, so we're.
Right.
A needs assessment.
Right.
Yes.
So that'll all be looked at once it moves over to capital, so that's great. So we have a first and a second, all in favor?
Aye.
Okay, so motion passes. So we will go ahead and bring it to the board, but Kevin will give us the information beforehand, so we know we're set where we need to be. Okay,
Very
thank you
good.
so much.
Thank you very much.
Okay, next we will be moving on to Sunnydale Nursing Home admission policy for non-Will County residents. And we have our executive director, Becky Helgerson, here today. Make sure you just push your little star so you're on.
Okay, well, it looks like we're at the final change in this because of our number of bed reduction. This was created back in the beginning of time because I'm guessing when Sunny Hill Nursing Home opened up about 50 years ago, that it only took Will County residents. And it was very clear that that was the process. And at one point in time, and that was in 1985, we had this resolution created so that if someone did live in the county at one point in time, they could come back and go into the nursing home if needed, or if they had a child that lived in Will County, they could come and live close to their child. So the numbers have been a little, they started out at 300 and they were reduced throughout the years, and now we just need that final number changed on this resolution because the old resolution doesn't make any sense anymore. Since our capacity is 156 beds. So what we're saying is that as long as our capacity is up to that point, we will only admit Will County residents. Once it gets to 146, which is 10 less than what we have, then we will start to consider other people to fill those beds so that we don't have empty beds. And that's the point of the resolution.
Right. Go ahead, Beth, do you have a question?
I just mostly want to make a comment that I appreciate that I know a lot of people in my age group are struggling with taking care of family members, and the fact that you can have your parent who might have been living with you but not having a taxpayer, I think that gives the flexibility that we need, and I just really support this.
Right, right. And I think that's the reason that it was actually started in the beginning.
For
So-
instance, my dad, he lived in DuPage County, and I was able to bring him to Sunny Hill.
Yes.
And so then he's closer to me here. And and we know it's a good facility, he gets great care there, and I don't have to drive to DuPage County. So that's nicer to have that ability, so.
We don't have a lot of use for the whole resolution right now. We're just doing it to clean the books up because our waiting list is a mile long. But we obviously need to be prepared for that at any time in the future. So
That's great.
that's it.
Okay, everybody? All right, can I have a motion to approve? Moved by Gould, second by Ferry, all in favor? Aye. Motion is approved. Okay, next we are moving on to renewing contract for nursing services for CNA, LPN, and RN in a nursing home. Rita, you're on.
Good morning.
Good morning.
This is just a simple renewal of our current contract with outside services for contractual CNAs, RNs, and LPNs. This is the final year of the renewal. We do only have 3 of the current 4 companies that have agreed to the renewal. Delta T Group backed out. They didn't give a reason, but I know that Becky has agreed with me that they are using all 5 of the 6 companies on the list, as well as additional companies that they've had to go to outsource these services when they have call-outs and call-offs. So this is the final year of this bid. When we go out to bid next year, we will make sure that we incorporate the other companies that she's currently using so that they're able to bid on it. But she does keep track of the contractual hourly rates and make sure that they're within reason.
Okay, all right, that's really good. And I know from my dad being there and my grandmother had been there, if there's any time we have an issue with somebody who is, an outside agency, that is addressed immediately. And most of the time, you don't know who a staff member is an outside agency is, so we have a real good group to choose from for those times that we need that. So, okay, can we have a motion to approve?
So moved.
Second.
Moved by Dellinger, second by Ferry, all in favor?
Aye.
All right, thank you, Rita.
Thank you.
Okay, next we are moving on to our child and adolescent presentations from behavioral health. Michelle Zimbrano. And Sue Lyon. Hello, thank you ladies for coming today. Yep.
All right, I just wanted to give some information about our child and adolescent program. Just to let you guys know, just to kind of keep passing the word along that, we are available for services. We operate Tuesday through Saturdays. We have night and weekend appointments. We provide individual, family, and group therapy, as well as low-level crisis stabilization, as well as case management. We provide therapeutic services for all of Will County residents that need. We go all the way down to Wilmington, Braidwood. We go all the way up to Naperville, Aurora. There's parts of Aurora that are Will County. There's parts of Tinley Park that are Will County. We cover all of that area. We also do have psychiatrists and staff that are there Tuesday through Saturdays. We have 2 of them. We are primarily, our staff is primarily office-based. The clientele that we serve are usually ages 2 years old, all the way up until 18, but sometimes we do keep them if they are 18 and still in high school, or sometimes if they're in the special ed program to some of our local high schools, that we let them stay there until they're like around 20.
Good.
Some of the diagnoses that we treat there are ADHD, depression, anxiety, conduct disorders. Currently, we have 5 full-time CNA staff, child and adolescent staff. An average caseload for each of those staff is about 111. Yes. And right now, for our county fiscal year, at this time, we have had 3,937 kept appointments. So as of December 1st of 2016. We have our intake, just for you guys, that in case you have any referrals that we'd like to pass our intake number along, I included that there. And also too is there are no waiting lists. Some of the issues that we address are the children are expressing suicidal and homicidal ideations to their families, to their friends' parents, to the school personnel, to their friends at school.
And that's one of the ways that we get referrals. Another one is that some of the schools and even the families will report withdrawal from family members, withdrawal from friends, withdrawal from classes, where sometimes they might have been like B students and all of a sudden they're F students, that the schools will make us aware. They'll give us a call and say, we have a kid, what do we do? We give them the intake number, they come through, and we try to get them to the root of the problem that's affecting the child. Kids, some of the other things that we do is we do work with the court system. We also work with the schools with the kids that are exhibiting violent behaviors, aggressive behaviors, because with some of the kids that we've dealt with, symptoms of depression sometimes come out in anger, violence. So we get those referrals. We get referrals from the community. We get it from different other agencies that are notifying us that this is too high risk for them. They want to refer it to us. Sometimes it's that they need medication, so that they'll refer to us. The high schools, we have a really good relationship with the local schools in all of Will County, not just in the Joliet area. We go into, if need be, we go in and see some of the kids at the schools in Wilmington, Braidwood, in Bolingbrook, wherever the kids need us. And if the family says, you know what, we can't get to your offices, can you come and see my child here? All of our therapists have, at one time or another, have gone to the school to see them. It's not something that's on a regular basis. It's just to kind of see what's going on and make sure that everything's okay. We do some advocacy with the schools for IEP, which is individual education plans. That's for kids that have been determined need a little bit more support services to get them through the academic school year. So we do some of that where we are advocating for our child and for our families at the IEP.
Before you move off the
Sure.
piece about the school, can I ask a question?
Sure.
As a former school board member, I know for a lot of years when the schools experience children with those issues, do you all have to get parental consent to go into the school before you talk to them?
Yes,
Okay.
absolutely.
Okay.
Yeah, and that's always something that we make sure that, and usually it's for our child and adolescent program, it is usually when we go there is at the parent's request.
Right.
Because what happens with a lot of our kids too is that parents become disabled. Sometimes it's grandparents, sometimes the parents got a new job where I can't be bringing them in all the time. Can you see them at the school and see what's going on?
But a dean or a counselor can't call your office about this 16-year-old child?
No, and not have us go. They can call and say,
right.
what can we do?
Correct.
And ask them questions, and we would
Okay.
guide them through the system. But no, we
Okay.
do not at any time circumvent the parent
All right.
or the guardian. Absolutely not. Any other questions?
Maybe you can just talk a second about how this program is different than SAS.
Okay.
Last time you were here, we talked about SAS and about children and adolescents as well,
Right.
just so that you kind of understand the nuances making difference.
Okay. With the SAS program, it is mainly community-based. I would say 95–96% is community-based, and it's about crisis stabilization. What happens is that the child and adolescent program is the next step down. Once SAS has stabilized them, then they make the referral for just therapy. They don't need to be seen a couple times a week. They don't need to be seen every single time at the school. They don't need to be seen at their home. The family has indicated it has been, the situation has been stabilized, and now we can bring them in. We kind of got a hold of it, the problem, and now we're making a referral. And with our SAS program, they can refer to child adolescents, but they can refer to any other agency that might better suit the child. Does that make it a little bit clearer for us, the difference?
So can I ask the
Sure.
full-time people, are these just designated for this program and you have different ones for SAS?
Correct.
Okay.
Correct.
Does a client need a certain kind of insurance, or absolutely anybody is able to get services? I mean,
It's anybody except for HMOs, because with HMOs, we're not a provider of that.
Okay.
But any MCOs, Medicaids, we do private insurance. We actually have some that they come self-pay. And what we do is we have our intake and our reimbursement work with them about seeing if they can qualify for public aid.
Okay, so
Most
that's
of
really
our-
good to know.
Yeah, most of the clients in the CNA is our Medicaid, they're Medicaid clients. Or people that don't have the ability to pay. We're not talking about a large, you know,
Yes.
a lot of people having Blue Cross, Blue Shield,
No,
PPO. It's not that group, it's a group of Medicaid, self-pay, don't have a lot of resources.
Right, it's usually about, with our Medicaid population, we're probably about 85–90% of them are on public aid.
So if a client came in that has HMO and you're not able to service, is there some kind of referral established, or is there some other
Yes.
community? Because I'm understanding the insurance that you have and the services that are open to you are usually connected, usually problematic. So what happens in that case?
Well, what we do is our intake worker has been directed that we have some agencies in the area that we've already called and said, what services or what insurances do you cover? We also do encourage them to flip over their card and call and see. But I know, as we all probably have tried to call that number on the back room, and we don't really get an answer. So what we did is we have some agencies that we know that will accept that or accept that particular issue.
Our intake staff and case, we have a case manager that works on this to try to link services and
Right.
everything. They do a really good job at doing this.
Right. Yeah, so we don't just kind of hang up the phone and be, good luck, and then.
We know it's important to make those linkages and to try to get that parent and that child services.
Susan, is your fee sliding scale, or is it one fee, depends on the income, or is it one fee for everybody?
We have a sliding fee
You do?
scale of behavioral health, yes, we do,
Okay.
just like we do at the health center.
Good, good, okay.
And then we also have some that don't have the ability to pay.
So indigent, they don't have to pay?
No.
No, okay.
Well, they don't, yeah.
If
There's a
they-
process that we have to go through to determine refusal to pay as opposed to unable to pay.
Right.
And, you know, there are a few that are truly unable to pay. And we don't want to have to not provide them services.
And especially with our since it's with kids, most people are qualified for Medicaid, but it's a complicated system. And a lot of the parents that aren't on it, it's just they need someone to kind of guide them through it.
Right.
And to explain some things, because a lot of times it does. There's a lot of questions and there's a lot of things that they may not know the answer to and just give up.
Right.
Or also too, the transportation to the place, or having somebody meet them there to advocate for them. And so with our reimbursement and our case manager, we can explain that a lot clearer to them, and to advocate for them. And with our therapists too, is because with the public aid, we are able to backfill. So even if they don't have it right now, once they qualify, we can go back and public aid will cover that.
Actually, two of our reimbursement specialists in behavioral health are navigators. About 3 or 4 years ago, when the ACA came out, and you know you could get grants to teach people to be navigators and ACA counselors, we had several people throughout the entire agency go to the training, and 2 of our reimbursement specialists in behavioral health had the training, so they are very adept at trying to get these people on public aid. There definitely is what we call a health literacy problem, where people are, you know, they're very taken aback by the language, the process, and so our staff helps them through that. Yeah, it's confusing.
That's
It
tough.
can be.
I know the more positive terms when I suffer from health illiteracy. I don't know,
You take it to where you want.
uh, Okay, that's great, a lot of information, and it's great that you guys go out to the schools to give them a hand, because sometimes, I mean, I know there's counselors there, but you do need that extra, but I think they know all the resource officers. and-
Yeah.
Right, which is great.
And also too, is what some of our CNA staff also do is if there's a crisis in the school, and sometimes the schools do reach out to us to ask us to come and do some counseling for the kids that might have, you know, if there was a suicide in the classes, or if there was a trauma, a sudden death, that sometimes the kids are coming and it seems to be too much for the school social workers, they'll ask. And a lot of our child and adolescent program staff will come and do some on-site therapy or crisis grief therapy.
Which is good, that doesn't.
Michelle, is this phone number then, the number that someone would call, no matter what that, whether it's SAS or it's the same number, or is this?
SAS is more of, since SAS's care is a crisis, is for us, for anybody to qualify for our SAS program, they have to go through the CARES line. And again, I think I gave it to you guys on the last sheet, the CARES line. And once the CARES line then calls the staff, it calls staff, but you
Not
can't,
one number to
right,
call
no, you
in
can't,
and-
right.
Here's line of goes, that process.
Yeah, because the state insists that we all go through, the whole entire state goes through the CARES line for any kind of staff services. It's got to get, that's the clearinghouse. But for the 5911, the 7275911, that is for our child LS, the Will County Health Department. And I just want to say thank you very much for, I don't know who it was that was passing the word along to some of the agencies, but we did get some phone calls asking about the SAS program and getting some clarification from some of the different schools. So thanks, that was really helpful. So some of the schools that we might have missed, that was awesome. Thank you so much.
That's why I really like to have our different agencies come forward, tell us what they're doing so that we get a good feel for it, and then we always take our meeting minutes and we have recordings of it, so anyone interested could pull that up and say, oh yeah, we discussed it then, they could go back and review it and then get that bit of information, know something before that.
Excellent.
Thank you, ladies, so much
Thank you
for
so
coming
much.
today, thank you. Okay, we're gonna move on to other new business.
Sue, can you just stay there for a second?
Me?
Yes.
Oh, okay, sorry. I didn't hear what name you said.
Sue. Right, Susan. Last Board of Health meeting, you brought up that, speaking of next year's budget, it's about $900,000 gap, I think, between what the department requested and where, at least where your levy was in terms of last year's budget. Okay. Can you tell the committee where that's at right now and, you know, what you foresee between now and when the budget's released?
Certainly. As you all know, the county departments were required to submit our finalized budgets to the county finance director by now, and we have done that. The budget for the health department has a negative over $700,000 in our budget. That's our gap, and that's how the budget was submitted. I was submitted that way because of my wanting to wait to find out if there can be some additional help from the county in terms of either reducing some of our expenses or increasing our revenues. The Board of Health at, I believe, their June meeting passed a resolution to request that the county increase our levy so that we could keep our services at the, sustain them at the current level. And the other thing that we were requesting possibly is maybe some centralized infrastructure services so that the health department wouldn't have to take on all those expenses. I'm talking about security and snow plowing and grass cutting and cleaning services and those kinds of things. The health department pays for all of those services out of our budget. Not every county department pays for those services out of their budget. We do. To the tune of almost $700,000. So that would be helpful to us as well to reduce some of those expenses. So the budget was submitted with a over $700,000 gap in the hopes of seeing if the county can help us with this issue. Now, in the meantime, we're just not sitting back and hoping and praying that we get money. We're actively doing some other things. One of them is looking at our fees, which we do every budget year. On some of our programs, we have kind of a cycle that we have established, and we look at them every, like, say, 3 years, 2 years, depending on what the program is. And this, in preparation for the next fiscal year, our food fees are due to be increased. The last time we increased any food fees, and we didn't increase all of them, it was just a few, was 2014. So certainly we are in the process of doing that. I've been working with Tom Casey, who is our environmental health director, and he and I have been working for the last couple of months on putting together a new fee structure as well as changing the ordinance. Environmental health is now going to the FDA food code, which is a big change in how we inspect restaurants. And so we're going to be changing the food ordinance to address both of those things, both the fees and the FDA food code and how we'll be doing inspections. So we're in the process of looking at that. I will be presenting at our September Board of Health meeting a request to have our board increase our food fees. We took a look at all of the collar counties, just as Dr. Shield was talking about. You know, it's a very common practice. You look at the collar counties, see what everybody else is charging, you look at what your expenses are, et cetera. And we will be able to increase our fees pretty well. It's been a while, like I said, for some of them to be raised, and when we're looking at Kendall County, Grundy County, DuPage, Cook, McHenry, Lake, we're behind. And so we'll be able to increase those fees. And of course, we'll have a public hearing. I've talked with Karen about the October committee having a public hearing, and then hopefully the county board approving the fees if the Board of Health approves those fees. So that could gain us, you know, at least a couple $100,000. I don't know what that final number is. I hope it's a little higher than that, but that helps bridge that gap. That 700, and I think it's like 714,000, that negative $714,000, that also includes us already putting in $250,000 out of our cash reserves. So our gap was larger, it was closer to $1 million. Now, I don't want to throw in a lot out of our cash reserves because I would like to build up that cash reserve over, you know, the next 2, 3, 4 years so that I don't have to come to the county board and request an inter-fund loan be put into place like we did this year. And by the way, we haven't had to use that money, so just wanted to point that out. But so that would eliminate us from having to do that. And I know that one of the questions I was asked at the county board meeting was, well, why isn't your cash balance higher? Well, it's not higher because every year we have to put money from the cash reserves to balance our budget. So it goes round and round. So the other thing that we're doing is I brought this, you know, we have this issue whereby every year we have a large gap. The last few years our gap has been anywhere between $800,000 and $1 million. Some years it's been more, and that's why we've had to cut positions. Over the last 6 to 7 years, we have cut almost 100 positions within the agency. And when I look at the public health, when I look at the programs that we have now remaining at the health department, we have all public health programs left, except 2 main programs. One is our community health center, and one is behavioral health. Those 2 are not typical public health programs. Everything else in family health services, environmental health, EP&R, those are all our core required programs. I can't cut any more of those programs. There's nothing else to cut. The next large cuts that have to take place will be behavioral health or the community health center. Those are not required programs. Now, I'm not saying, and I said this at our meeting, I'm not saying that what we do in those programs isn't required or necessary or great. They are. They help the community. They're necessary programs in our community. Otherwise, we wouldn't have tried to, you know, create them and run them. But there's a point where, as a public health administrator in a public health agency, I have to look at core public health. So that's why I'm requesting more money. That's why I'm trying to increase fees. That's why I'm trying to do whatever I can to sustain our programs. But I don't know how long we can do that. At the Board of Health meeting, our Board of Health President, Jim Zelko, tasked all of our division heads over the next few months to take a very, very comprehensive and critical and out-of-the-box look at all of our revenue, all of our expenses. And to be quite honest, we've done that to a great extent, but we will continue to do that and be creative. And so we're looking at program sustainability over the next few months. And then without an influx of a lot of revenue, we will be at the same point next year. And so that's where we're at.
Well, thank you. I appreciate the explanation, because I wanted everyone on the committee to be aware of exactly where, first of all, what the challenges are within the health department, and secondly, where they're at in terms of next year's budget. I've got a question for you. That's something you just said. in other counties that have community health centers and have behavioral health, do those programs operate within a health department, or are they operated independently, or both ways? How do other counties approach those functions?
Well, the one that I can probably compare us best to is Lake County Health Department. They have all the complementary programs that we do, as well as behavioral health and community health center. However, they have a larger tax base. They have, more money. They have several health centers, and they have several behavioral health centers throughout the county. So they have economy of scale to a large extent. We have one health center, which has one CMO, one CEO, one operations director, and a management team. And that only is supported by one health center. Whereas in Lake County, I honestly don't know how many they have. I think they have more than 5 or 6. So they have an economy of scale there. They're getting revenue from all these different sites, but they have expenses that, aren't,
I understand.
you know what I'm saying? So it is.
What about behavioral health? How does that
Behavioral
operate?
health, they do run out of Lake County as well, Lake County Health Department. As a matter of fact, they're expanding their behavioral health program right now. Kluber, who is our architectural and engineering firm, they're actually working with Lake County right now to repurpose a building to expand their services. I don't know how much levy money they get for that program. Their program is run pretty much the same way we are, as far as Medicaid and billing and MCOs and HMOs. I mean, the way it's set up, they have to go by Medicaid Rule 132 as well. So I don't know. We're going out to Lake County Health Department soon with Kluber to kind of look at how they're set up, and we're hoping to see. We're not hoping. We will see some efficiencies gained and some streamlining with our new facility. That I know we will, because we're so spread out in this old, mispurposed building, that we will see efficiencies. And if we could just hold it all together until then, and maybe we can, gain some, or decrease our expenses and gain some efficiencies that way, which will really have a very positive impact on our budget.
Thank you very much.
Okay, Mark, you had a question?
I didn't have a question.
Or comment?
Comment, yes,
Sarah?
I have.
And District 13 has 2 what I would call gated residential colonies for seniors. And I just want to publicly thank Tom Murray and Harold Damron, because tomorrow they're going to put on a presentation over at Carolina and then Grand Haven. I don't know if they're going to do them consecutively or not, but tomorrow they're going to put on a presentation all about the Ready Will County app that you get on the phone. It'll probably be a more extended presentation than we got, because there might be a little coaching on how to download an app and stuff like that. But I want to thank them 2 guys publicly, because they always cooperate with whatever you need. And also, I went to Suwalenic to get some other programs going on at these 2 residential colonies, as I call them. And we got to talking about a few things, and I thought maybe they could produce some kind of presentation on what grandparents should know about the opioid crisis, and right away they're ready to cooperate. So thank you very much for all your cooperation, all your help. Thank you.
You're welcome. All right, that's really great. Go ahead, Jim.
I have a couple of questions. One on the budget, one on the community health center. What's created the gap? And the reason I'm asking, if the levy, if right now the assumption is the levy is staying the same, and you have a $700,000 gap, actually probably more, close to $1 million gap, what created the gap?
Well, I think one of the things that creates the gap over time is the increases that the bargaining unit get. If you go back, I don't have the document in front of me, I wasn't prepared to speak to it technically, but
doesn't have the exact numbers, just in general.
I know I did some math on this last year, and I think our levy, over the last 7 to 8 years, our levy didn't increase by more than 2%, but the levy, but the increases for bargaining unit went up like, I don't know, 17% or something like that. So it's a huge effect because, if the bargaining unit get, 3.5%, then that rolls into the next year's budget, and then they get another 3.5%, that rolls into the next year's budget. Health insurance costs have gone up, they've not gone down. We're at 17,700 budgeting for next year. We were at 17,300, I believe, last year. So $400 when you have 276 people, that's a large number. So I think that kind of rolling over every year has made the gap go larger. It does cost more to operate the facility. The two medical pieces that I was speaking of, which is the health center and behavioral health, they have electronic medical record systems which are required. There's a lot of compliance issues and a lot of, I don't want to say issues, compliance requirements that we're required to follow, and we do. Accreditation is very much encouraged. As you know, the community health center was just JACO accredited, and our behavioral health division just received CARF accreditation again. So, and both of those divisions are expensive divisions as far as personnel. You've got doctors and nurses and psychiatrists and psychologists, senior therapists. So the budget grows.
So this is not the cause of a one-year event or 1 year. So what you've been doing is you've been carrying over operating deficits annually. So you've been kind of rolling, handling it through cash flow, whatever.
Well, we've been handling it through getting rid of programs and positions. As I said, over the last 7 years, we eliminated several programs and about 100 staff.
See, there's always a little disconnect. If you've been laying them off, and then you're saying that it affected because of wages, well, it's not affected wages, you've been laying people off. I don't want to get into a big debate.
But can I speak to that, though?
Yeah, sure.
When you do lay people off, and this is something that I don't know is common knowledge, but when you lay people off, for example, we laid off 25 people in family health services last year. And when you lay off people, we have to go by the prescribed, prescribed method in our bargaining, collective bargaining agreement. And that is by bumping. And so your most senior staff bump your less senior staff. So in your budget is left your most senior staff. So you don't save the money that you think you're gonna save. All your, all your lower paid staff are eliminated, and you keep your higher paid staff. So those nurses or those therapists that are making $60,000, $70,000, $80,000 a year, they're still in my budget, not the ones that were making 40 or 45.
I understand, but it was cover pay increases. I don't want to get into a debate. I'm just asking.
Right.
Is this something that you've had a deficit that's kind of rolling operationally? You've covered it one way or the other.
Right.
Whether it's through cash flow and temporary loans, whether it's using reserves, however you did it.
Right. It was a combination of all of those things. Exactly.
The other thing I want to ask you is about the healthcare center. Originally, it was the healthcare center, the Will County Healthcare Center. And then we became a federally qualified healthcare center, which qualifies us for federal funding.
Right.
It also created a separation between the health department and the federally qualified healthcare center. Separation in the effect that they have their own board. And certainly there was a lot of discussion early on who ran the healthcare center. The health department or the health center board, and it gets a little fuzzy. And I'm not. Don't necessarily want to revisit that, but I do think for people who may not be aware of. It's a federally qualified healthcare center, which runs under certain federal rules.
Right.
and certainly, and in most cases, can run independently. We have gone to Washington and have asked for additional funding because our reimbursement rate is on the lower side compared to the rest of the country. Of course, I don't know where these things stand in the federal budget these days. But I do think it's worth noting that they have certain level of independence from the health or the health department. And there is other federal funding, and they do work under federal guidelines. So maybe this is more of a comment for me about, I think there's different ways of approaching the healthcare center. Granted, the county or the health department, they own the building and so forth. But the program is basically not necessarily a health department program, it's a federal program. And I know it gets a little gray.
Yes and no.
I know, I know it gets a little gray in there. I'm not looking at, but I'm just saying there may be other ways of approaching the healthcare center. That's all.
Sure, and a lot of that, I wasn't in this capacity or anywhere near this capacity when all that was taking place, but I do know that the two bodies, the Board of Health and the Governing Council, which is the governing board for the Community Health Center, they came up with a cooperative operating agreement, and that was to just say, okay, you're responsible for this and we're responsible for that. So that's been all clarified, and things are going well. The Governing Council is responsible for the operation. In other words, the CEO would have to go to them for changing hours or for policy approvals, those kinds of things. And that happens every day. We had a meeting last night. However, the funding is strictly through the health department. All of the funding comes from the health department budget and is provided to the health center.
It comes from the federal government through the health department.
Part of it, part of it, 1.9 million out of a $8 to $9 million budget.
I'd actually like to see a separate accounting for the healthcare center between what is provided by federal government, state government, and what is paid by. I'd actually like to see what the actual operating deficit of the healthcare center is.
This year, in this current budget, it's $2.5 million, but that's not including any part of the levy. That's just strictly all of their revenue from federal and state and all of their expenses. That's not including any levy dollars that they would get.
The county puts in, through the levy, $2.5 million in the healthcare center.
Probably about $2.
All right, about $2. So, which I think is, even though it's a significant number, it doesn't create, it's not what creates any real operational, well, if there's a $2 million deficit, operating deficit, I think there's ways we can approach that, but I just wanted to point out that it's a separate, the actual money that goes in from local dollars is I don't want to say $2 million isn't significant, but it's not as significant as you may think. So I just really want to draw that out from committees. When you start talking about like the healthcare center, behavioral health, I have to say no, little or nothing about how that works. I assume we pay for just about all of it. But same thing, I'd like to see in behavioral health, what is actually the county's operational deficit? Because I don't know what gets reimbursed, I don't know what comes in the form of user pay and so forth. It would be helpful, I think, to know those things. That's right. Rather than always looking at a lump sum, and especially in those two, that are optional in the sense of we're not required to run.
Right. And certainly our Board of Health obviously is provided with that information. I mean, we present to them, every month our financial status and revenues and expenses for each division and each part of the operation. And I just want to make sure that everyone understands that difference in the health center of that 2.5 million, that's not including any that's not including any levy that typically goes in there. So I want that clear. Okay, so we have a good basic understanding right now, and she's talking about her issues and budget, and Jim is asking for some more information, so hopefully that'll be coming out in some future meetings that will be held, so, okay. Any other new business? Good. Any public comment? Public comment from anybody? No? All right. Chairman's report announcement. I do have an announcement I passed out to everybody. A friend of mine is involved in this. She's also a resident in County Board 1. It's Freedom Sunday. It's Sunday, September 24th. And they're having an anti-human trafficking community awareness presentation. That's at the Moni Free Methodist Church. And the purpose of this is, I'm not sure how many people are aware of human trafficking and how it impacts our residents in Will County, so it might be something you might want to attend. I'm aware of it because of her, and also I attended a Zonta event in Kankakee County, and Hoekstra Trucking is very involved in human trafficking, and they train a lot of their semi-truck drivers to be able to spot it. So that's something I will be bringing forward for us to have as a presentation in the future. But for right now, if you're able to attend on the 24th of September, that'd be a great, process for everyone to attend and maybe get a little feel for it. So I just wanted to announce that. That's all I have. We do not have executive session, so I'll have a motion to adjourn. Motion. Moved by Ferry, second by Militello. All in favor? Aye. All right, we're adjourned.